My name is Hamnah. I'm a first-year cardiac surgery resident here at the University of Toronto. So today I'll be talking about the right ventricle through the eyes of the surgical side. As cardiac surgeons, we do rely on the echo report quite a bit, but sometimes we ask for things that don't obviously get reported, and sometimes things are reported and we don't even know what they mean. So the RV is a great example of that because it's hard to image. It's oftentimes underappreciated compared to the LV. And yet it turns out to be very important in how we plan and run our operation. By the end of the talk, I want to have a shared language about the RV, specifically RV morphology and function, and how that changes our operative plan and predicts our outcomes, and then intra-op, the troubles we have getting off pump when there's RV dysfunction, and then post-op as well. So what we'll cover today are essentially these three main objectives. So from morphology to the OR plan, RV dysfunction in the operating room, and then the key questions that we want to know about the RV. So let's start with why this matters. So for a long time, the LV was, getting all the attention, but across multiple studies, the RV size and function turns out to be independent predictors of outcomes. In a recent review, pre-existing RV dysfunction was associated with longer ventilation times, longer ICU stays, and higher mortality after cardiac surgery in general. Other studies have shown that in patients with severe LV dysfunction undergoing CABG, so coronary artery bypass graft, it was the pre-bypass RV dysfunction, not just the LV function, that independently predicted poor outcomes. There was another study that showed simple RV myocardial performance index predicted perioperative mortality or circulatory failure in high-risk valvular surgery. And in the LVAD world in particular, RV failure after a continuous flow device remains one of the major drivers of early mortality and morbidity, and that occurs in a substantial amount of patients. So the RV for sure is not a bystander. It's a chamber that determines whether a successful operation on the other side of the heart actually translates into good outcomes for the patient. So this is the first sort of bit that we're going to talk about, is just the RV anatomy, function, and how the findings change the plan. So let's start with the anatomy, because I think that sort of explains everything else. So anatomically, the RV is conventionally divided into three parts. We have the inlet, so the tricuspid valve, its subvalvular apparatus, and the papillary muscles. And then the apical trabeculated body, so the RV has this heavy trabeculated myocardium, which is why the RV endocardial borders are notoriously hard to trace on the echo. And then the infundibulum, or the RVOT, is just a small walled conus that sits just below the pulmonary valve. So in cross-section, the RV is actually crescent shape, and it wraps around the LV, and there's no single, one plane, and no single surgical view actually that shows you all three of these components at once. So that's why a multi-view approach, so parasternal long axis, RV focus, apical four chamber, subcostal, and parasternal short axis all contribute different pieces. Second, the free wall of the RV is actually pretty thin. It's about 3 to 5 millimeters, and it's pretty heavily trabeculated. So that's very practical surgical implications for us. So it's pretty unforgiving if we place vents, cannulas, sutures. It does not tolerate aggressive retraction well. And then the RV sits anteriorly, right behind the sternum. So when we open the chest, the first thing that we actually see is the RV. So it's the chamber most exposed to direct trauma as well when we do a repeat surgery. So why does the RV behave so differently from the LV? And the anatomy sets up some really important physiological differences. So like I talked about, the RV is thin-walled, it's compliant, versus the LV is thick and has this concentric wall. What's very interesting is that the way that the RV and the LV contract are different. Contraction is predominantly longitudinal, with the free wall basically moving towards the septum and the tricuspid annulus moving towards the apex, whereas the LV actually contracts radially, circumferentially, and then there's this torsion that's associated with the LV as well. The coronary supply is different. The RC, the right coronary artery, mainly supplies the right ventricle, and then the LAD and the circ mainly supply the LV. And then probably the most other important part is the last two on the table that you see. The RV tolerates volume reasonably well. So it's a compliant chamber, but it tolerates acute pressure or afterload very poorly. So a ventricle that's thin-walled can dilate quickly, but it fails quickly when the afterload goes up suddenly, right? So if there's an acute pulmonary embolism or if there's residual pulmonary hypertension after a valve procedure. And then there's also this idea of ventricular interdependence and the pericardium. So the RV actually gets a meaningful contribution to its performance from the septum and from the constraining effects of the pericardium. So the moment we open the chest, both of those contributions change, which is something that I'm going to come back to. So sizing up the LV, so this is how you can quantify the RV size. So quantitatively, in a proper RV focused apical 4-chamber view, the RV should not be more than 2/3 the size of the LV. And the LV should be forming the cardiac apex. So as soon as you see that and that's not the case, so that's when you want to start measuring the RV. And so, there's a lot of numbers here. I can never remember them. But the whole point is that what these numbers describe is remodeling, right? They tell you about chamber geometry, which usually reflects a chronic process. So volume overload from tricuspid regurg, pressure overload from pulmonary hypertension or congenital disease. But they do not tell you whether the muscle itself is contracting well. So you can have a big RV that can be squeezing fine, and a normal size RV can actually be failing. So that's why we need to also quantify RV systolic function, how well the muscle is actually contracting. And the more commonly reported parameter is TAPSE, which is tricuspid annular plane systolic excursion. So as you see in the schematic on the left, you put your M-mode cursor through the lateral tricuspid annulus in the apical. So you put your M-mode cursor through the lateral tricuspid annulus in an apical 4-chamber view, and you measure how far that point of the annulus moves towards the apex during systole. And a TAPSE under around 17 millimeters is considered abnormal. And then there's other parameters as well, like fractional area change under 35% is abnormal, tissue Doppler S prime at the tricuspid annulus, and then RV free wall longitudinal strain that's less negative than about minus 20%. So here's sort of the important caveat, and I'll flag it again later because it's very relevant to what we see in the operating room. So the TAPSE parameter and the S prime only capture longitudinal function. So they're angle dependent, they're load dependent, and they fall significantly after any cardiac surgery that involves opening the pericardium. So as soon as we open the chest, we open the pericardium, both those parameters fall, even when the overall RV function is preserved. But in a pre-op clinic setting, a low TAPSE is a meaningful red flag. So in a patient who's just come off bypass, a low TAPSE needs much more context before you can claim that it's RV dysfunction. So the next concept I think is also very useful, RV pulmonary artery coupling, and it's becoming a lot more prominent in our surgical literature as well. So the idea is that RV function can't be interpreted in isolation from what it's pumping against. So a normal TAPSE in a patient with severe pulmonary hypertension might actually represent a heart that's working extremely hard to just maintain a normal number. It's compensated, but there's little reserve left. And then you have the TAPC to the PASP ratio, and that's also a non-invasive way of capturing that relationship. And it correlates well with the gold standard pressure volume curve that measures the RV arterial coupling. So on the graph on the right, we see the x-axis for the afterload, so the pulmonary artery systolic pressure, and then on the y-axis we see TAPC as a surrogate for the contractile reserve. And then there's this described threshold in literature of about 0.31 mm per mmHg, and below that, the RV is considered uncoupled from its afterload, and that is associated with significantly worse outcomes. Originally described in pulmonary hypertension populations, but now it's starting to be used more broadly as well. So why does this matter to us as surgeons? Because the question I care about isn't whether is this RV okay now? It's what happens to the RV when I change the afterload. So every cardiac operation has the potential to change RV afterload through cardioplegic arrest, through reperfusion, through correcting or not correcting a valve lesion, through residual pulmonary hypertension. A coupled RV has reserve to absorb that change, whereas an uncoupled RV may not. So let's sort of bring this together into concrete clinical scenarios that I'll go over very quickly. So if a patient has severe tricuspid regurg and they're referred for repair, what I want to know in the echo report is the RV size, the TAPC ratio, potentially RVPA coupling, and GLS. And the reason is that tricuspid regurg causes RV volume overload. So if we wait too long, the RV remodels in a way that it doesn't reserve even after a technically perfect repair. So these parameters do influence timing, and early referral for a dilated, still functioning RV can factor into repair versus replacement discussions. And then LVAD candidacy is also really, really important. Patients identified as high risk for post-LVAD RV failure may need a planned strategy for temporary RV mechanical support or a stage approach rather than finding about like RV on the table. And then there's also the cases with valve. So say you have a mitral valve patient with long-standing pulmonary hypertension. So all these parameters that are listed there, it changes how aggressively we plan to monitor the patient, whether we need pulmonary vasodilators, what are our thresholds for starting inotropes early rather than reactively. And then there's also in the congenital world, it actually influences the types of valve replacement we do, the conduit, and the patch strategy as well. So the common thread basically across these four is the same handful of RV parameters come up, right? Size, function by more than one metric, and coupling to afterload. And each one has a specific downstream effect on what we do in the operating room, not just whether we operate, but when and how. So this is just an example of RV dysfunction after tricuspid repair. So we see the RV barely moving, and this one is a better example as well. So now we're going to talk about RV dysfunction in the operating room. So why the RV basically struggles during heart surgery. So there are several reasons the RV is particularly vulnerable intraoperatively, and I think understanding these sort of helps make sense of what you see on a post-bypass TEE. So air embolism, so the right coronary ostium is actually the most anterior and superior of the two coronary openings. And after we come off pump, when we are de-airing the heart, which means we're just getting out the residual air from the heart, any residual intracardiac air actually tends to rise and enter the RCA first. And so that can cause a transient ischemic insult to the RV. So what you'll see on the echo at that point is you'll see new regional hypokinesis and sometimes transient ECG changes, but it usually resolves over a few minutes. You tell the staff, and then we do different things so that the air clears out. And then cardioplegia distribution. So if cardioplegia delivery is uneven, so for example, if a patient has AI, so aortic regurgitation, and that prevents good antegrade delivery of cardioplegia, or there's significant right coronary disease, or we only use a retrograde strategy, the RV free wall can actually end up pretty unprotected compared to the LV. And then the cross clamp itself affects the RV disproportionately compared to the LV, so it is prone to ischemia. And then there's also acute volume and pressure overload when we come off pump. So if there's new or residual TR, or there's a stiff like pulmonary vascular bed after valve correction, that can suddenly overload the RV that was previously compensated. And then two more subtle points. So as I mentioned, simply opening the pericardium, you reduce the longitudinal shortening. So the TAPSE and the S prime drop even in a heart with preserved global RV dysfunction. And then obviously all the other stuff that we do in the manipulations to the heart. So coming off bypass, essentially here we have a checklist of the things that probably like the most useful for us and what we should specifically be looking at on the TEE report with respect to the RV. So first, has the RV gotten bigger compared to the pre-bypass study? That's the most basic signal of a new problem. Second, look qualitatively at the RV free wall contractility, especially the apical and the inferior segments. So remember, that's where the right coronary artery territory is, and that's where the air insult usually shows up first. And then also the concept of septal flattening. It's also a classic sign of RV pressure or volume overload. And then is there new or worsening TR, and why is that the case? Is it from annular dilation because the RV just got bigger, or is it from leaflet tethering? And then has the estimated PA pressure, the RV outflow Doppler pattern changed? Is it better or worse? And then sometimes we even ask intra-op to look at the IVC flow patterns as well, because that can tell us a bit about the RV filling pressures intraoperatively. And like I said, don't overinterpret a low TAPSE in isolation after bypass. So these are sort of some checklists that I would want to know in the echo report, and they're just basic questions, but they actually tell us a lot of different things. So again, basic things like what's making the apex up? Is the RV dilated relative to the LV? Are we dealing with chronic remodeling or acute? Is the RV systolic function preserved, and is it by more than one parameter? And what's the pulmonary artery pressure? So a normal RV with the normal PA pressures is very different from a normal RV in front of severe pulmonary hypertension. Is there significant TR, and why is that the case? Because we would want to address it in the operation. And then is there RVOT or any pulmonary valve pathology? So that will directly impact our incision planning, our cannulation, our conduit choice, and especially for the congenital cases. And then is this dysfunction acute or chronic? So an acutely stunned RV, let's say after an inferior MI, it behaves and recovers very differently from a chronically remodeled one. And then this is obviously very important for us, is how is the RV going to tolerate bypass and whatever afterload change the operation will produce? And this last question sort of feeds into all the ones above. So a structured RV path from start to finish. So putting it together, when a patient comes in for an elective surgery and they get a pre-op echo, we want to establish the baseline. We want to look at what is the size of the RV, how is it functioning, and then possibly any coupling, and then the TR mechanism and RVOT anatomy. And what that does is it sort of feeds into risk stratification and a discussion within the surgical team about timing, technique, and anticipated support needs. Intraoperatively, before we go on pump, so that means before we cannulate, the TEE confirms that baseline and sort of sets our reference point. And then post bypass, once we're starting to come off pump, we do a structured RV relook. We compare it to the patient's baseline, and if needed, we escalate support in a stepwise fashion. So Sort of the same core principles apply whether you're scanning in clinic, in the pre-op holding area, or on the table. And then good echo and surgery communication is not just about a report, it actually influences the plan that we do intra-op. So the take-home points that I want everyone to take away is that to remember the anatomy, right? So the RB is thin, it's crescent-shaped, and it is afterload sensitive. So there's small changes in whether pressure or volume that can have significant effects on the RB. And there's no one echo parameter that's going to tell us everything about the RV. We need to have a whole picture about size, function, coupling. RV dysfunction before or after surgery independently predicts ICU stay, ventilation time, and mortality. We've seen again and again patients with normal ejection fraction that are in the ICU because they have RV dysfunction. And intraoperatively, the RV is specifically vulnerable to things like air embolism, uneven cardioplegia, ischemic reperfusion, and acute loading changes after bypass. And then we talked about sort of the surgeon's 7 questions from size to function to coupling, and then the expected tolerance coming off bypass that will essentially turn the report into our plan. So these are my references. Thank you so much.